All right, let's go ahead and get started. Hi, everyone. My name is Hamera Osman. I'm the VP of Research and Public Policy at Muscular Dystrophy Canada, and welcome to today's Let's Talk NMD webinar. We're really excited to have this webinar as it is one of our ways of celebrating and recognizing Myasthenia Gravis Awareness Month. June is MG Awareness Month, and I'm really pleased to have this education session based on the input. Many of you have reached out to MDC's research hotline to learn more about the treatments that are coming to market for MG that are in the pipeline. And so really looking forward to today's session. And we have Dr. Barnett Tapia here today to deliver today's talk. Dr. Barnett Tapia is a neurologist and a scientist. She received her medical degree in 2004 and completed her neurology residency in 2007. She completed a fellowship in neuromuscular conditions and a PhD in clinical epidemiology and healthcare research at the University of Toronto in 2015. Her research is focused on patient-centered outcomes research in neuromuscular conditions, aiming to incorporate the patient's view and preferences into clinical trials and practice. You really are very patient-centric in your research and in your work. So over to you, Dr. Barnett Tapia.
Hey, Humera, and thank you for having me. And I'm really excited to talk about some of the new treatments are upcoming for myasthenia gravis. So if you're following the field, you'll see that over the past 5 years, we've had a number of new therapeutics for myasthenia. And one of them is a class, there's different medications in this class that are called the FcRn blockers. And I'll tell you what they are. So, you know, what's available in Canada, what will be available in Canada, I'm hoping very soon. These are my disclosures for this talk. And these are my objectives. So what I hope for all of you who are joining today to learn after this talk is to get a better understanding on myasthenia gravis. I know many of you know about this, but it's always good to go back to some of the basics of how myasthenia gravis happens in the body and the role of antibodies, because these treatments are focused are taking away the antibodies from the system, and how these medications work, how well they work, in whom and when can they be used, especially the current status in Canada. So just a few words, myasthenia gravis is a rare disease. If you're joining, you either are a patient with myasthenia or perhaps a caregiver or work with people with myasthenia gravis. We estimate that there's roughly 30 people with myasthenia over 100,000 people worldwide. We've done studies in Canada and we get roughly a similar number. So we estimate using this number that between 11,000 to 12,000 people live with myasthenia gravis in Canada. So with any rare disease, the disease is rare, but there's a lot of people living with myasthenia. Myasthenia gravis, the most common myasthenia gravis form that we see, is an autoimmune disease. It means that for some reasons that sometimes we don't understand, the body produces antibodies. Antibodies are the structures in the body, proteins that help us fight germs and fight bugs, and they're good for us. But sometimes the body develops antibodies that attack the body itself. And these are autoimmune diseases, and myasthenia is one of them. So in this diagram, in this nice plot, this is an actual picture of a muscle. All these nice pink long lines are little muscle fibers. And this black thing here, this is a nerve. And you see the nerve is going to the muscle. And this little kind of button that you see here, that is where the nerve and the muscle are communicating to each other. And that is the neuromuscular junction. And that is where the problem is in people with myasthenia. So this is a nice diagram kind of to show that this connection that seems very simple, just the nerve going to the muscle, is actually a very complex structure. So in this picture, the nerve is in green, and we have the muscle here in kind of pink. And you see there's a number of structures there that mediate the information from the nerve to the muscle, and finally allowing the muscle to work and, you know, and do all the things we do. In myasthenia, especially acquired myasthenia, we have antibodies that attack this connection. The most common antibody is against the acetylcholine receptor, which is this structure here. So most people with myasthenia have this type of disease, and that antibody doesn't allow the information to go from the nerve to the muscle and produces some damage to the muscle membrane. And this is why people with myasthenia have weakness in different muscles. So we simplify, but this is actually a very complex process. And I promise all the basic stuff is almost done. There's different types of myasthenia, and this is important because many of our treatments are dependent on the type of myasthenia and the antibody. So as I mentioned before, most people with autoimmune myasthenia have this type, acetylcholine receptor antibodies. This is somehow between 80 to 90%, 8 to 9 out of 10 people with myasthenia will have this type of myasthenia, the most common one. Some people have a slightly less common form called MuSK. This is a different structure and presents a little bit differently, and that's around 8 to 10% of people. There are other rare antibodies, and really important, I know many patients don't have measurable antibodies. They have symptoms of myasthenia with the testing that shows that this connection between the nerve and the muscle is not working properly. They respond to treatment, but we don't find the antibody. Okay, and this is important because, as I'll show you, some medications are approved or are useful in different types of myasthenia. So how do we treat myasthenia? There is two big ways that I like to separate them. One is treating the symptoms, so helping patients feel stronger. And the other one is treating the underlying cause of the disease. So treating the symptoms is saying, well, we will not do anything to the antibodies or the immune system. We'll just make that connection between the nerve and the muscle more efficient, and people will feel stronger. So for those of you in the audience who have myasthenia or know someone with myasthenia, the most common treatment is something called pyridostigmine, or the commercial name Mestinon, which is a medication that often works really well. And it just makes the connection a little bit stronger. Okay? It works for a lot of people, but it's not a cure. It doesn't treat the cause. And in some patients, it may not be enough if the symptoms are more severe, where there is a need to treat the underlying cause of the disease, which most patients need at some point. And that, because this is an autoimmune disease, that means your immune system is dysregulated. That means that we have to either suppress or change the way the immune system works so that we have fewer antibodies that are causing the disease. Some patients need both approaches. Some patients do well with only symptoms. Some patients do well with just managing the underlying cause. And sometimes we start with lots of things, and then we can take things out, and we hope to use the smallest amount of treatments that keep someone doing well. Now, the immune system is a very, very complex thing. So it spans multiple areas in your body. So in myasthenia, many of you have had a thymectomy or have heard about this. The thymus is a gland that we have behind your breastbone. It has to do with production of antibodies. And in myasthenia, we know that, especially for the most common type of myasthenia, the acetylcholine receptor positive myasthenia, the onset of the disease is linked to the thymus, and the thymus can produce antibodies. So this is why many patients are recommended to have a thymectomy, even if you don't have a thymoma or a tumor of this gland. But the immune system goes beyond that. So we have cells that produce antibodies in your bone marrow, in your lymph nodes, and many parts of your body. And those cells produce lymphocytes, and then they produce antibodies that end up attacking the nerve and muscle junction. So we can try to change the course of the immune system in different areas, either by taking the thymus out, by reducing the amount of lymphocytes you have in your blood. So many of the medications used, like steroids, or if you've had something like azathioprine or mycophenolate, they work by reducing the amount of white cells that produce antibodies. And some of the newer medications work in a different way. FcRn blockers, which is what you've asked me to talk about today, don't change the production, rather take this out of the circulation, and I'll tell you more about that. And some other medications like complement inhibitors that you may have heard before for myasthenia don't have anything to do at all with the number of antibodies. They just prevent damage in the muscle. So they can work in different places. So this is kind of a way that I simplify this in my own head. We can either stop or reduce overall antibody production. So most of the treatments that we have available do this, like prednisone and typical immunosuppressant agents, with the problem that they're not targeted. So they kind of wipe out different lines of white blood cells and can cause many other side effects. If you have heard about rituximab, that attacks a specific line of B cells that's useful for some types of myasthenia. We can also remove the antibodies. So they're still being produced, but we're taking it out so they're not causing problems. You may have heard of plasma exchange, or you may have had plasma exchange during the course of your disease. This is a procedure where they remove the blood from your system, and the blood goes to a special machine that takes away all sorts of antibodies, useful and not useful, and other substances in your blood, and then returns the blood back to the circulation. So that works really well, but as you can imagine, it's quite an invasive procedure, and it's also quite limited. In Ontario, we only have 3 hospitals that have this, so it's not something that can be done in a broad population of patients. So oftentimes plasma exchange is reserved for people who have a crisis or very severe disease where we have no other options. You may have heard or you may have had IVIG, that's intravenous immunoglobulin. So that is a blood product. This is antibodies from healthy donors. So people donate their blood, they just take away the healthy antibodies, they mix a pool of multiple donors, and you get this, this product. So we don't know how IVIG works. We have many theories. One of them is that it neutralizes the abnormal antibodies and kind of takes them away from the circulation, kind of washes them out, among other theories. But in all honesty, no one knows 100% how is that IVIG works for myasthenia. Some people cannot have IVIG. Some people get an adverse reaction that is incompatible for us using it, or have other medical conditions that preclude for using IVIG. And this also, in this line of removing the antibodies, is where this new line of drugs, the FcRn blockers or inhibitors, work. They also remove the circulating, and I'll show you how they do this. It's actually a very clever mechanism and class of medications. And then the third is downstream. So if you've heard about complement inhibitors, and we have some approved in Canada, they don't stop the production, they don't remove the antibodies. So we have this similar amount of antibodies circulating, but we prevent those antibodies from causing damage at the muscle membrane. So different ways we can try to target the immune system to improve the symptoms of myasthenia. So for this very specific talk, I'm going to tell you about the FcRn blockers. It sounds like a handful, but it's a very clever mechanism. So our bodies are amazing machines, and they're very efficient in trying to prevent infection. So antibodies are one of our lines of defense, and IgG, that type of antibody, gives it has to do with chronic protection to some infections. Our body is very clever, and instead of wasting a lot of energy in creating more and more and more of this IgG, of this antibody, our body recycles this, the IgG, and brings it back. So we all have antibodies in your blood, and every once in a while, these antibodies are picked by cells, and our system says, well, these antibodies are useful for us. Instead of destroying them, we're going to protect them and bring them back to the blood. So that way our bodies are recycling the antibodies that are already there. And this is why our antibodies last for a long time in your blood, the IgG. This recycling procedure is mediated by this little thing, the FcRn, that protects these antibodies from being destroyed and send them back. So when we block this thing, the FcRn, these antibodies are no longer protected for destruction in our blood, and instead of being sent back, they're destroyed. So what this medication is doing is removing the IgG, these antibodies, from the circulation. Some people have called this chemical plasma exchange or chemical plex. It's doing a similar thing whereby we're taking these antibodies from the circulation, except that we're not doing it by connecting you to a machine and taking your blood out and cleansing it and put it back in. We are doing usually an infusion of a medication that does this process. So the antibodies are still produced. It's just they're being taken out of the circulation. And as opposed to plasma exchange, which is this big machine and taking all the blood, this medication only reduces the levels of IgG, other antibodies like IgA or IgM, other antibodies that you need for protection of it against the bugs and for other things are untouched. So it's a little bit more specific and is in that regard associated with less concerns of infection. Like with plasma exchange, that's a big concern of people, our likelihood of infections. But it doesn't stop the antibodies from being produced, and that's important because we don't think this alone will help patients go into remission. The antibodies are going to still be produced, but it's very good at taking them out of your blood. So we have multiple now agents in this class. They all have names that are hard to pronounce. I put them here in the order of when they are being or likely to be approved. The one we have approved in Canada is called Efgartigimod. The commercial name is Efgart. This is approved. It's available in Canada, and there are Canadian patients who are receiving these. It's very new, so it's still kind of in the early stages. And I'll tell you more about this. This has been used in the United States for over 2 years now. So our colleagues in the States actually had quite a bit of experience treating people with myasthenia with this. We're just gaining that experience. Rosanolixizumab, and that's a handful. It's taken me like 3 years to learn how to say that. It's been approved by the FDA. It's under review in Canada, and we have the expectation that this will be hopefully available within this year, early next year in Canada. So that's what we're hoping for. And these other two are now on trials. So we may come to the hopefully nearby future where we may have not 1, but 4 different drugs in this category doing available for myasthenia. And when you have different medications that work in the same way, it gives people options because they may have different side effect profiles. Some may be administered in different ways, and that gives patients choices and options to find the best medication that adjusts to their specific individual conditions. Okay, so let's go a little bit more in to see how well these medications work for myasthenia. I'm going to talk first about Efgartigimod because it's the first one that's been approved and is actually available in Canada right now. So Efgartigimod is a fragment, it's not a full antibody, it's just this little piece of the fragment here. Is this Fc, so this is what an antibody looks like, an IgG, and this is just this fragment that is designed in the lab to bind to this receptor and to block that recycling of the antibodies. Okay? It works very well. It reduces all types of IgG, and the IgGs are the ones that are related to myasthenia gravis. So these are the type of antibodies that cause myasthenia, but it does not reduce other antibodies like IgA, IgD, IgE, or IgM that are very important for protection against other diseases. So this is actually very, very important for us. This is just to show you how well it reduces the levels. So this is a lot of information. So in these plots, in the lower bit here, this is when you start. And at the doses that we're using now in trials and for humans, you see how the antibodies drop. And as long as you're giving the infusion, they remain low. So we know the same for acetylcholine receptor antibodies in the studies. When we give these medications, the antibodies drop in the blood of patients with myasthenia. Now, what you are interested in is not for me to show you all the basic stuff. You want to see how well it works. So we have plenty of studies in myasthenia. And Efgartigimod, the big trial that led to this medication to be approved in the States, Canada, and many other countries is this. What I think is really interesting is that this study included people with the most common type of myasthenia, which is the acetylcholine receptor positive. But they also had people with MuSK myasthenia, which is the less common subtype, and even people without antibodies. And this is really exciting to see because until now, people without antibodies have been excluded from all trials. And that's a problem for us because when we don't have studies, we do not know what's the best treatment for that group of patients. And when a drug is approved, it's only approved for when it's shown benefit. So if we don't do trials for people without antibodies, we will never have any new drug approved for that group. So it's really important that we have some of this data. So there are patients with myasthenia, GMG, the G stands for generalized. So you'll see all these studies are done for people where myasthenia is affecting muscles outside the eyes. They can have double vision or droopy eyelids, but they have to have some difficulty swallowing or chewing or speaking or weakness in the arms or the legs or something like that. So it's for generalized. We don't have studies for people with only eye symptoms. And people have to have at least mild to moderate generalized disease. They have to have a minimum degree of symptoms. So people with very mild symptoms would not qualify for the study. And the patients could receive the medication. And this is an intravenous medication. So it's an infusion that needs to be done once a week, 4 times in a row. This is what these arrows mean: 1 week, 2 weeks, 3 weeks, 4 weeks. And that's considered a cycle. So they could get either the medication or placebo. We see how well they respond, and then they could be retreated. Because remember, this is not a medication that's permanent. If we don't retreat patients, the level of antibodies that dropped will going to increase, and patients are going to need some other treatments. Okay. So this is the main thing to see here. In this plot, we're looking at 2 scales we use very frequently for studies of myasthenia. One is where patients respond about symptoms that they have been having. And this one is patients come and one doctor or an examiner looks at how long they can hold their arms or their legs, how long it takes them to get double vision, etc. This point here is when they start. Red is the group that received placebo, and blue is the group that received Efgartigimod. And you see that there is a big difference between the placebo group and the Efgartigimod group. You see this big difference means that people in the Efgartigimod group changed by close to 5 points over here at the peak of the response, whereas people in placebo changed for less than 2 points. So this is a big difference that's significant, both from numbers, but also from clinical perspective. See the same thing here, a dramatic difference between placebo and the patients who were treated. The other thing that is really important is that this happened fairly quickly. So this is 1 week, 2 weeks. At 2 weeks since the first infusion, patients were already improving quite a bit. And by the end of the cycle, there was a big difference. So the effect of these medications is fairly fast. It's similar to what you would see sometimes with IVIG or plasma exchange, where we often see the effects in about 2 weeks, but much faster than you would see with other of our medications. So if you are a patient with myasthenia and you are taking something like azathioprine or mycophenolate, your doctors probably told you that it takes many, many months for those to kick in, often at least a year. So in comparison to those medications, this is quite fast. And on the right-hand side, on this plot, this looks like an asymmetrical Christmas tree. We're saying how many people responded to treatment. When we talk with patients about new treatments, a common question is, well, how many patients respond to these? What are my chances of responding to this medication? In this case, you see that almost 78% of people who receive the medication improve by using this scale. And if you wanted to see people who responded by more, so more strict or have a higher response, then it goes up, and it's much bigger than placebo. And if you use the other scale, it's about 74%. So what we can say is that we expect that roughly 3/4 of patients will respond to treatment, which is a very good number. A little bit over 7 out of 10 or 3 out of 4 will have a good response to this treatment. So a high number of people responded. I should go back and say that the majority of patients in the study were acetylcholine receptor positive, even though the study did include some patients with masked myasthenia or negative. Those numbers were very small. So most of the analyses were done in people with acetylcholine receptor positive. So this is mostly reflective of that population. The second question patients usually ask is, well, let's talk about safety and side effects, because there is no intervention or medication that doesn't have side effects. Everything has a possibility for side effects. So overall, the profile looked really good. This is here in the first part, placebo versus the patients who received the medication. And you see that about 80% of people in the placebo group reported any adverse event, and it was very similar to people in the treatment group. So there's no major difference. Severe adverse events, 8% in the placebo group and 5% in the treatment group. So no significant difference, and we were not seeing a signal of more severe events in the treatment group. So this is what we want to see. We look at infections because we are removing antibodies. So anytime you reduce the immune system in any way, even if you're targeted, you will have a risk of infections. And yes, there were infections, and 46% of the treated versus 37% of placebo. Most of the infections were mild, so upper respiratory tract infections, that's like a common cold, some urinary tract infections, but really overall milder infections, some headaches associated with infusion, but that was the same. And here you always see COVID in all the new trials because all these studies were done through the pandemic, so you'll see how many people have had COVID, but you see no major differences. So overall, the safety profile has been really good. Keep in mind that the first here is 6 months. These are new drugs. We don't have a lot of data, although there's been an extension looking at up to 3 years. And again, the findings are fairly similar with some side effects and some infections, but overall mild. So we don't know in the long run, so we cannot tell you 10 years down the line because that data doesn't exist, but we can tell you that in the short to medium term, the safety profile looks to be very good. The other thing is the duration. Because each cycle is 4 weeks, we want to know how long it takes. So the other questions some of my patients I have put in this drug are like, well, how often do I need to have it for? And at first the answer is we don't know because it is different for different patients. So in the studies, there was a number of patients, over 30%, so 3 in 10, that needed a second treatment 12 weeks after the first. So they had an interval that they didn't need a new treatment that was quite long. Some patients needed to be treated earlier, within 8 to 12 weeks. Some patients really had a very short interval. They needed to be treated within 4 to 6 weeks. So there is some variability from patient to patient, where they may need the cycles to happen more or less closely together. And as far as I know, we don't have any way to predict who will need the short or the long. So what we are recommending for patients starting this medication is we're trying to put everyone on a fixed schedule that's every 4 weeks, just to see that the medication works, that there's no major side effects. And once we are convinced that patients are responding and patients are stable, we'll try to spread those the time between infusions, between cycles, so we can make it longer, but it would be on a case-by-case scenario. But there is room for personalizing this a little bit. The other question is, well, patients get better. How many patients do really well? Because you may be a little bit better, but you may still feel very weak. So You may feel a little bit stronger, but you may not be able to return to work or to care for your family. So the other question is, how many people do very well, that they have very little symptoms? One way we measure this is called minimal symptom expression. It's not perfect, but it's just saying that patients are having very low scores. So overall, they're doing fairly well, although again, there's some caveats to this. But just to look at the difference, 40% of patients with the medication reached that threshold where they were doing very, very well compared to 11% of placebo. So not only a large number of patients respond, meaning they feel better, but there is a reasonable number of patients who also have excellent overall long-term treatment where they feel really well. So what's the current status? In Canada, Efgartigimod is approved for people with generalized myasthenia gravis, and it's only approved for people with antibodies against the acetylcholine receptor. So I know I mentioned that in the study, they did include people with MuSK or seronegative, but unfortunately, those numbers were too small, and they couldn't see enough of a difference. There was not enough power to say that it was also effective. So in Canada, you have to have the antibodies to be able to access this medication. Now, the reimbursement, and in Canada, we have different agencies that look up when and how medication should be paid for by the public healthcare system. And this is also something that private insurers use. And this follows the clinical trial. So besides being generalized and besides having the antibodies, you need to have a minimum score in the scale. So you need to have some symptoms that are not being controlled. And these symptoms have to be persistent despite the use of some of the traditional treatments for myasthenia. In other words, this is not a first-line treatment for myasthenia. It's not something your doctor would start right off the bat. Patients would start on common standard medications that work on many people. But if those medications are not enough and you still have enough symptoms that are within this kind of cut point, then that's the patients where this medication would be approved. Not approved for MuSK. We don't approve it for crisis. We don't have data. So if someone has an MG crisis, meaning they're in the hospital and difficulty breathing, then those patients would not qualify. This is something that's not for crisis. And patients with pure ocular myasthenia. So those of you who only have diplopia and double vision and droopy eyelids, and you don't have generalized, this medication is not approved at this point. The second medication I'm going to touch briefly is because this medication I'm hoping is going to be approved soon. Rosanolixizumab is also a medication that works in the same way. So it's also a blocker of the FcRn receptor. It's a full antibody. So instead of being just that little piece, it's the whole antibody that's also binds in the same way. So it does the same thing of reducing the circulating antibodies that cause myasthenia in the blood. They also did a very big study with comparing different doses and placebo. One difference is this is a subcutaneous infusion. So rather than being through a vein, it's administered subcutaneously under the skin. And the study, the treatment was once a week by 6, and then they had an observation period, and then they looked at this in length in other 1 year and several months. So there's been different patients that have been tried in this medication in the multi-center studies. And this plot looks very similar to what I just showed you for Efgartigimod. You see the placebo arm is here, and you see that with both doses of this product, the patients feel better. There's a drop in the outcome scales that measure disease severity. You see that by 2 weeks, we're seeing significant improvement, and that kind of peaks around after the last infusion, 6 to 7 weeks. And again, if you don't treat this again, the patients go back, because remember, the antibodies are still being produced. So this takes them out of the circulation. So patients need to be retreated. And again, there's different times when people may need to be retreated. That's to show you, but placebo, very little change at day 43 and a big change with the medication. So again, a very effective medication and a similar number of respondents than Efgartigimod. Okay. In this case, in this study, they had a larger population of people with MuSK myasthenia, And it just happened that everyone who had mask myasthenia in this trial responded. The response rate was 100%. All the mask patients responded to treatment, and people who were, the overall population was about 70%. So this is similar to the other, and the mask patients here did really, really well, and there were 12 patients. And this is why I'll show you why this medication, because of this, is approved for mask myasthenia too, at least in the United States. In terms of side effects, again, first we want to see efficacy, we want to see safety, very similar pattern of safety and adverse events compared to Efgartigimod. So again, about 50% of patients have any kind of adverse event, headache, diarrhea, fever. So all those are related to the infusion being more common. And in terms of infections, similar, generally mild infections, like a common cold, some urinary tract infections, but overall, a very similar pattern between the placebo and the treatment. Headache was most prominent, and that's clearly caused by the medication, but it's transitory, and that goes away with some medications. So what's the status of Rosanolixizumab? It is approved by the FDA and other agencies in other countries. Again, only for generalized myasthenia gravis, but in this case, it was approved for people with acetylcholine receptor positive and mask positive. So now the approval is a bit, the population is a little bit more expanded. It's under review by Health Canada. If approved, I believe, and again, I'm hoping that that's the case. I suspect that the approval may be similar to the FDA. So I'm hoping that it's going to be approved also for mask and acetylcholine receptor positive. And I suspect the reimbursement conditions, so in which patients we will have this covered, would be very similar. So again, it would not be first line of treatment. You would have to have the antibodies. You would have to have generalized disease. You would have to have a minimum amount of symptoms, and you would have to have tried some of the most common treatments and have those not working properly before this could be an option. So when, as a clinician, am I thinking? I do have some patients receiving these medications. There are patients with generalized myasthenia that we have tried standard of care and have persistent symptoms. So I have patients who have not been well controlled and have tried IVIG and have had a severe complication of IVIG that we cannot do that anymore, or did not respond that well to IVIG. If we're thinking about IVIG or plasma exchange, so if your doctor is thinking about that, this might be a good alternative, and patients who cannot get IVIG plaques for any other medical reasons. There's a lot of things we don't know. These medications are fairly new, and this is things we are researching and hope to get answers in the future. Some kids and adolescents get myasthenia gravis, and all the studies are in adults, so we don't know how well and how safe these drugs are in kids. We have a lot of young women who have myasthenia gravis who may want or have a pregnancy. We don't know the effect of these medications. The receptor that this medication blocks is important in pregnancy because it allows the antibodies from the mother to pass to the fetus, so that protects the baby in the first months in life. So may not be a great idea, especially in the last trimester of pregnancy. And again, we don't have much data on this. We don't have data about how good they are with crisis. Are they better or the same or worse than the standard of care? We don't know. We don't know about seronegative myasthenia gravis. They have been included in the studies, but as you know, very small numbers. But I can tell you that I know at least of 2 studies now that are specifically looking at seronegative myasthenia with this drug. So I'm hoping that we'll have some data. We don't have data of pure ocular myasthenia, but I can also tell you that there is a study underway looking at FcRn blockers for pure ocular myasthenia. And we don't have long-term data. The longest is a few years. We will know more as these medications become more commonly used and we have people follow for long times. What are the long-term implications of having these medications? So in summary, what I hope you learn is that we are very excited because this family of drugs are going to be a very useful addition to our current therapeutic arsenal for treating myasthenia gravis. Again, it's not going to be first line. It's very focused yet for people with specific conditions. For now in Canada, only if you have the antibodies, but I suspect that may change in the upcoming years. And again, they may need chronic use. So this is a question. They don't stop the production of antibodies. So if this is the only treatment, it will have to be kind of permanent. but it may be a nice intermediate treatment, if you're receiving other things and we're waiting for other medications to kick in to get patients a rapid improvement in their symptoms to help them, go back to where they are as soon as we can. And I believe that's my last question, and I have some time to take some questions. Thank you very much.
Thanks so much, Dr. Barnett Tapia. That was a really well-delivered and clear presentation, and you really did answer the questions that were set out. If it's okay, I'm going to go ahead and read a few questions that we have received, one of which is, why isn't it a first-line treatment? Or really, what constitutes a first-line treatment then?
That's a great question. So first-line treatments are what's already available standard of care. So first-line treatment include pyridostigmine or mestinon, which is that medication that treats the symptoms. Some patients, believe it or not, are only treated with that and they do well. So there's some people who have milder disease who don't need their immune systems to be treated in any way. The other first-line treatments are prednisone and other immunosuppressants. So why are these medications not first-line at this point in time? There are multiple reasons. One is that in the studies, all the patients were on other medications. So they really have not been studied as first-line. We don't know how well they work as first-line of treatment. Two, many patients do really well with first-line of treatment. So many patients do well with the most common low doses of steroids and pyridostigmine with very little side effects and have very good outcomes. So many patients do well with what we have without having to have infusions and have all that other assessment, all that other interventions. And three is probably also associated with cost. These medications are very, very costly. So I don't think any healthcare system could use these medications as first line for all the people with myasthenia gravis. And therefore, they're at this point kind of left for people who need that extra treatment. The other thing in the flip side is that some of the first line treatments, so say like things like prednisone, for instance, actually can get you into remission. So patients can go into remission, meaning no need for other treatments or just very little doses for life. And some patients, even sometimes as a small number, can go out of treatment completely. These medications, especially the FcRn blockers, they won't induce remission if you just use those, because the antibodies were going to still be produced all the time. So if you just wanted to go and use one of these, you would have to take one of these forever. The chances of this, just the disease disappearing, are very low because the antibodies are going to be produced and the symptoms are going to be controlled only as you use this. We don't think you'll be able to necessarily reduce the doses or stop them altogether.
That makes a very good sense. Thank you for answering that question. The next one is that it's from a patient who is MuSK positive, and they mentioned that you noted that this, the FcRns that you mentioned are not necessarily for those with MuSK positive. Do you know of any treatments that are on the horizon for those individuals?
So Efgartigimod, that is currently approved, is not approved for MuSK, but Rosanolixizumab, who hopefully will be approved, may be approved for MuSK. So I think that will be one option. People with MuSK myasthenia respond extremely well to something called rituximab. Again, there's nothing that's 100%, but many studies have shown that that's something that we have available. It's sometimes not easy to get in Canada, and there's a lot of hoops we have to go through as physicians to be able to obtain this for patients, but many patients do very well with this medication. So I would say that if someone cannot get rituximab or doesn't have access to rituximab, probably Rosanolixizumab, who's I'm hoping is going to be approved, will be an option for MuSK.
That's great. Can you clarify whether patients who would be taking, like, let's say Vyvgart, for example, would they take it with steroids simultaneously, or is it one or the other?
Excellent question. So for the current scenario, so say the patients I have, this would be an add-on, right? These are patients who are not responding very well, or they have some response but still have symptoms. So in myasthenia, when we add a medication and then someone is doing well, we start taking things out. So if I have someone on steroids and they're not doing well, they still have symptoms, I put them, say, on Efgartigimod, and they do well, then we will start to take the steroids out. This medication should work in reducing steroids, and in fact, some data has shown that they do. So we always like to take them out. Because they're not first line, we are not in the position where we would start them necessarily at the same time at this point in Canada, right? But let's say in a theoretical scenario, I think in the States, they may sometimes get it earlier than what we will be able to do in Canada. So you may start with both, and perhaps once you're well controlled, this Efgartigimod, you know, could be tapered off. So there's no one choice. But if you are on steroids and your doctor puts you on a new drug, the goal would be to be able to come to a low dose of steroids.
Is Efgartigimod or other FcRn would be useful in the pediatric population? So this is from a parent with a child with MG.
So as far as I know, there are no data. In theory, they should work because the mechanism of action should work in children as in adults. I'm not a pediatric neurologist, so I don't know whether there are any concerns in terms of affecting other areas of the immune system in children if using these drugs. My understanding is there are people who are going to be doing studies in younger populations, but I think for now it's only approved from 18 years and older.
Another question is, how do we know when these treatments work clinically? How do you track progress with it? Is it the absence of symptoms, or is it the PASS, as you were mentioning?
Excellent question. So absence of symptoms is the holy grail, right? So if someone's symptoms completely resolved, there's no doubt that the medication is working. But that's not the case for a number of patients where the symptoms improve. So we do track symptoms. Different doctors may do this in a different way. In our clinic, we like questionnaires. So if anyone in this audience is, we ask patients to fill questionnaires and we track the numbers. For practical reimbursement concerns in Canada, if your doctor puts you in this medication, we actually have to fill a form with one of the scales and put a number. And for us to be able to renew this, we have to show that the patient improves by a certain amount of points. So the governments and the payers, so be it private or public, will require your doctor to put a number and show that that number is improving to be able to get it a repeated cycle. So they will have to track the symptoms with the MG-ADL, but your doctor may also use other scales. I like to ask patients how they feel with the medication, if they feel it's doing what it's supposed to be doing, but we will have a specific number for the paperwork specifically.
Is the side effects profile for FcRn inhibitors better than other mechanisms of treatment?
So I would say overall it's fairly safe. So with myasthenia, and anytime you touch the immune system, our main concern is infections. So this mechanism doesn't have the risk of meningitis that some of the other line of treatments for myasthenia have. You may have heard of the complement inhibitors like eculizumab or ravulizumab. Those have that risk of meningitis where patients need to be vaccinated beforehand. That's not a specific concern with this medication because that specific risk is not as high. There is a smaller risk of infections, but that seems to be pretty on par with other medications, right? So I would say that overall, and again, with the caveat that there's nothing without side effects and there's nothing at zero risk, I would say the profile looks very favorable compared to some of the other options.
Great. And then just one other question here, which is, do you know when the products would be approved in Canada or reimbursed?
I wish. I have zero knowledge or control on that. I can say, though, that Efgartigimod is approved. So the first hoop is Health Canada, that's passed. Then is the CADTH review. CADTH is an agency that assesses all the new technologies to recommend whether they should be reimbursed. So Efgartigimod received a positive recommendation. That usually means that the provinces and the private healthcare system will reimburse them. I also can tell you that there is a mechanism to obtain Efgartigimod through your neurologist if your neurologist thinks so. So the company has a bridging program for patients that we doctors feel they are in need of the drug and they cannot wait for all this process. So we have, we're able to put the patients in that drug, and that's ongoing. So as I said, I actually have patients who are receiving the drug through this program. For Rosanolixizumab, I do not know. I know it's under review, but I have no idea. I'm hoping perhaps at the end of this year or early in the 2025, but that I don't know.
As a neurologist that's been seeing patients with MG for a number of years, what does this all mean to you? Like this new period where treatments are coming to market, you're seeing approvals. What do you think that this will do in terms of patient experience and management?
Oh, I think it's so exciting. Up until 5 years ago, we tried all our standard care, and I have to say, many patients do really well with the old stuff. So a lot of patients don't need the new stuff. But we have a number of patients that despite being better, we were stuck. They're still having symptoms, they're still having side effects. And at some point, we had no options. I was like, there's nothing else I can offer. We've tried everything. And now I don't say that anymore because now we do have options, especially if you have the antibodies. So we have the complement inhibitors, we have had the FcRn receptors. And I'm seeing patients who have had a major change where they were really unwell and now they're able to eat again, where we're reducing the steroids, and that's something we couldn't have done a few years ago. So it gives us lots of hope for the future, especially for people with harder to treat disease or people who sometimes just cannot have some medications because of other diseases or side effects. I only talked about this. There's a number of drugs in the pipeline for myasthenia. There are studies looking at some of the cancer treatments, which is called cell therapy, which is one of the most exciting things I've seen in a long time, which is working a different way, probably for the most severe patients. But we're seeing in some studies dramatic improvements in patients with myasthenia that we wouldn't have seen a few years ago. So, I always tell my patients, it's not fun, it's not nice, it sucks to be diagnosed with a chronic disease. You'd rather not have a disease, right? But myasthenia is one of those that we can treat, that we have many treatments, many of them work really well, and so many new treatments that we can try. So it brings a lot of hope for us and our patients.
Absolutely. It's such a transformative period and it's really exciting. It does bring me to the last question, which is that if a patient were to access, some of the treatments that you mentioned today, does that hinder them from these possible innovative medicines that are currently being studied or that might be coming down the line? Does it work against them to access these medications?
I don't think so. So it's a great question because we run a lot of trials in our unit, and often we have very thorough inclusion-exclusion criteria. So some of these new drugs like Efgartigimod, Rosanolixizumab, they kind of wash away fairly quickly in the system. So if something new came where we thought there was a better option, many of the other new drugs require 4-8 weeks, so a certain period of washout. So there may be a transition, but especially FcRn and complements should not make that a very long process. Other things like rituximab, for instance, they can stay in your body for a long time, the effect. So sometimes people who receive rituximab may not be able to access a new drug for 6 or 12 months after rituximab. So that's just because it just stays longer in the body, but this usually is a shorter washout period.
Wonderful. So on that note, we'll go ahead and thank you, Dr. Barnett Tapia, for a really well-delivered, clear presentation today. Thank you so much. If you have any other questions for those in the audience and those who are watching this recording, please email research@muscle.ca. If we haven't got to your questions today, I'd be happy to take them and answer them or relay them to Dr. Barnett Tapia for response as well. And we extend our thanks to argenx, who provided generous support for this webinar and related educational initiatives at MDC. So thank you all so much. We wish you a good afternoon and a happy Myasthenia Gravis Awareness Month.
Yes.
Thanks again, Dr. Barnett.
Thanks for having me. Bye.